I welcome you all to this Changemaker20 Summit, and I would request Dr. Madhav Suri to kindly introduce each one of you, and then I will start the video. So I have received the access.
Thank you. So, thank you all for attending this patient safety meeting so that we can better understand what is needed for giving our patients better care and making sure they're safe while we give the care. So, first to present will be Charu Khanna, and she'll describe her experience with her daughter, and she will give more details, but her daughter had relapsing remitting multiple sclerosis, which is a very difficult disease to treat. She tried various medications. We were at the end of all treatment options, and finally she took an experimental therapy. And she'll describe what happened at that time and her experience with the disease. And this will be followed by Mrs. Japneet Bawa, whose child was diagnosed with epilepsy after having been diagnosed with seizures. She had numerous evaluations, and she will describe her experience, what happened to her child, and then how things evolved in a changing diagnosis, eventually where she is now, and her journey will be something from which we can learn a lot about how to deliver proper patient care. Well, we'll start first with a video coming from UCSF. At UCSF is Kiran Gupta. She is a professor of internal medicine, and she has a background in public health, palliative care. She trained at Harvard Medical School, at the Brigham Women's Hospital, at UCSF, and then established the UCSF's program of decreasing mortality morbidity, means a quality improvement program. And UCSF is one of the few hospitals that maintains an internal report card and monitors their performance. Now, we don't have access to that because it is proprietary and confidential, but we can say that there are various lessons learned from it. And Kiran was unable to come, but she's going to be present with us in a pre-recorded video, which is going to be played now.
Hi, everyone. My name is Kiran Gupta. I'm an associate professor of clinical medicine at the University of California in San Francisco, and for a number of years have also served as the medical director for quality and safety for the adult side of the health system. I will talk to you a little bit about some patient safety best practices, but then I'd like to spend most of my time talking about an innovative program we developed to help support healthcare providers and team members when there are mistakes, adverse events, and adverse outcomes in patient care. So one of the biggest challenges in the world of patient safety is understanding how do we even know how safe our healthcare system is or how our hospital is. And so, part of it is what you see, depends on where you look. And there are a variety of ways to measure safety, but I would say one of the biggest challenges is I don't think the field has fully cracked that nut. And so we look in a bunch of different places to understand how we are doing in terms of safety. And one best practice is that every institution really should have a way for clinicians and staff to report adverse events, mistakes, unanticipated outcomes so that we can learn from the things that are happening and actually try to make our system safer. And so for us, that's an incident reporting system. And it's a place where people can report things that are going on or concerns that they have. Another best practice refers to a process called a root cause analysis. And every healthcare system organization practice should really have a formal mechanism for reviewing things that happen and figuring out what happened, why it happened, and how to put actions into place to actually make things better and prevent them from happening again. And there are numerous resources out there to provide advice on how to best conduct a root cause analysis, and I won't get into that detail here. I think other best practices include routinely administering surveys to staff and providers to understand how they feel about the safety culture and the environment in which they work. And partly that's important because we know that a better safety culture actually is related to lower rates of burnout, higher rates of staff engagement, and presumably safer care. It's also important to routinely provide safety training to staff so that they understand what a safe system looks like. We also advise paying attention to things like Patient Safety Awareness Week and having routine campaigns related to patient safety. And then, of course, there are a variety of performance measures and external rankings that are established by regulatory agencies and other bodies to which healthcare systems are responsible for providing data, and then are evaluated as far as their performance across a variety of metrics. And the so-called pay for performance movement has actually been proven to improve the quality and safety of care, regardless of the fact that sometimes the methodologies and the approaches are critiqued a little bit, but measuring what we do is the only way that we can actually improve both the safety and quality of care. And so that's another important best practice just to understand. I think one of the programs I'd like to highlight, though, is a gap that we identified a few years back, which is that providing care to patients in a high stakes, high stress environment means that when the system is imperfect, which we all know that healthcare systems are not perfect, there are going to be mistakes that happen, and there are going to be adverse events that happen, even though everybody comes to work trying to do their best that day. And so the question is, what do we actually do to support the healthcare providers and staff who come to work every day facing the stress of this imperfect system in a high stakes environment where there's always another patient, there's more work to be done than there are hands to do it? And how do we help them when these things happen and help them go on to thrive in their careers? And so one of the most desired forms of support from people working in healthcare is that from a trusted peer, from someone who walks in their shoes. And so to that end, we actually built a program called Caring for the Caregiver, which is a peer support program designed to support providers and staff in the aftermath of patient adverse events, unexpected outcomes, and medical errors. And we called our program Caring for the Caregiver. And I will speak to you briefly about what I've been describing, which is the second victim adverse event aftermath phenomenon. I want to also talk a little bit about what second victims go through, identify high-risk scenarios which could lead to the second victim phenomenon, and talk a little bit about the kind of skills training we give to those people who will become peer supporters through our Caring for the Caregiver program, and review the Caring for the Caregiver program goals and logistics. So I want to remind everyone who does not work in healthcare that there is a cost to caring. Healthcare providers face tremendous degrees of burnout, vicarious trauma, compassion fatigue, moral distress, and then this phenomenon I've described called the second victim response. So some helpful facts that are quite troubling. More than 2/3 of physicians involved in an adverse event continue to suffer from troubling memories, anxiety, anger, remorse, and distress. And nearly 80% of doctors have experienced a distressing patient event in the last year. So that's a lot of people in healthcare walking around with a lot of distress. Another study, over 50% of traumatized clinicians are devastated by an event they did not cause. And 43% of physicians suffer from depression, anxiety, PTSD, or even contemplate suicide in the days and weeks after an unanticipated clinical event. Very sobering. And so this faculty member said that it's not a matter of if clinicians are going to experience trauma while providing care, but when and how often. And just a point to consider, some have critiqued this phrase, the second victim, saying that it places too much weight on those individuals who are providing healthcare and takes away from the distress for patients and families when there is an adverse outcome or adverse event. But none of these other terms that have been offered have really stuck. And so the literature does use this term second victim to describe what it is that physicians, nurses, and other staff taking care of patients experience when things don't go as planned. And so the second victim experience defined is really that of a healthcare team member involved in an unanticipated patient event, medical error, or patient-related injury. And the person becomes victimized in the sense that they are traumatized by the event. And so what are some of these high-risk scenarios for this second victim phenomenon? They include when a staff member really connects to a patient and identifies them in some way, the way they would a friend or family member. Maybe they look similar to their child, or they have the same disease process that the grandparent died of. Pediatric cases are always hard. Medical errors, especially for those at the sharp end, our proceduralists, our surgeons, when there's a mistake there, the ownership and level of responsibility felt can be tremendous, and the impact of the mistake can be devastating to someone's career. First death experiences, unexpected patient deaths are very hard. And then increasing rates of workplace violence, especially in the ER and on psychiatric wards, are very, very challenging for staff and providers caring for patients. What do doctors and staff taking care of patients tend to worry about? They worry first and foremost, is the patient and family okay? They worry about themselves and their careers. Will I be fired? Will I be sued? Will I lose my license? They worry about their peers and their colleagues. Will I ever be trusted again? Will people ever want to take care of patients with me again? What will my colleagues think? What happens next? And so what does a recovery trajectory look like for someone in healthcare in the aftermath of something hard that's happened to a patient? Well, there's the chaos of what initially happened. It's dealing with the code. It's dealing with the rest of the shift. It's dealing with whatever else has to be done in the real situation. Then there's the intrusive reflections that might kick in after a shift, and this desire to restore personal integrity and be trusted by one's peers again. And that's really the realization of the impact. Then there's this feeling of, oh my God, I'm going to have to endure the inquisition. And this feeling that people are going to ask questions and raise concerns, and how am I going to respond to that? And then maybe if they're lucky, they work at a place where they can get some emotional first aid. And most places, maybe it's a phone number they can call if they decide to call it. We know that people working in healthcare are not good at asking for help for themselves. They're used to helping others, and they have to move on. And the question is, are they going to move on and thrive and integrate what happened and be able to maintain resiliency in their careers? Are they going to simply survive, maybe doing okay from time to time, but still feeling impacted by what happened? Or are they going to drop out as a result of it? And this story represents the worst of what might happen if someone chooses to drop out after an adverse event in their career in healthcare. This is the story of Kim Hyatt, who was an experienced pediatric nurse who made a dose calculation error, a manual dose calculation error, a human mistake that any of us could make, especially when trying to tend to multiple tasks, being interrupted constantly, maybe taking care of more patients than we should be. And a baby overdosed under her care as a result of this manual calculation that probably the system shouldn't have been designed to require a manual calculation. And in that moment, she made a mistake. She was immediately put on administrative leave. She was given no support. And several months later, she took her own life. So not only in this case do we have the suffering of the baby, the family of that child, but then a nurse taking her life and the sadness for her family. And the question I raise is, could this have been prevented by providing the right kind of support to this person rather than just simply putting her on leave after she made a human error? And so research shows there is benefit to institutions financially for running these programs. A study out of Hopkins showed that their peer support program estimated a net savings of over $22,000 per nurse who initiated a call to the program. Their program is called RISE, or Resiliency in Stressful Events. And the other case for why we should do this is that it really represents one crucial component of working towards becoming a highly reliable organization in healthcare, and it's the right thing to do. You can't speak to clinician well-being unless you're adequately providing support to your clinicians. And so we give our peer supporters a variety of skills in listening and communication as they go through our training, and we've trained over 400 peer supporters around our organization. So what are the benefits of this kind of clinician peer support network? They include staff having a way to get their needs met after going through a traumatic event. It helps reduce the harmful effects of stress. It provides some normalization and helps the individual get back to routine after a traumatic event, and promotes continuation of productive careers while building healthy stress management behaviors. It's important to remember that no two people have the same support needs, and awareness is the first intervention. And remember, when things happen that are unexpected or hard, the fear of the unknown is profound. Challenges that are important to take into account when building support networks for clinicians. There's a stigma to reaching out to help that's real. People in healthcare are used to being the helpers, they're not used to getting help themselves. High acuity areas have little time to integrate what has happened. So the reality of the environment in which we work is the room's got to get turned over. The next patient's got to get seen. That surgeon needs to go in and do the next case. And do you want to be that next patient after something like this has happened? I'm not sure I would, but the reality is there's no time for people to process, to talk. Maybe someone who makes a mistake or maybe someone whose patient has died really should not have to go in and take care of the next patient right there in that moment. But our system isn't designed to create any buffer to accept that. There's an intense fear of the unknown. People don't want to talk about what happened because they fear they may compromise collegial relationships or face legal challenges, or violate HIPAA and other confidentiality implications. So the literature has shown that the most desired form of support is that from a respected colleague. And perhaps these programs that provide peer support will also reduce burnout and the adverse impact that has on healthcare providers. So what is peer support? We tell our peer supporters to think about it as emotional first aid. We train them in active listening, how to help those in need of support purposefully talk through their experience. And we also teach them how to help the person needing support to put things in perspective. So reasons our program has been activated include unexpected patient outcomes, tragic clinician events, and medical errors, among other issues. We have a website and a video. We provide our peer supporters with a variety of resources. And these are some highlighted stories as far as the positive impact of the work that we've done. And I would say one of the most gratifying things about this work is it's been a small way to change the culture at an organization. It's really asking our peer supporters to go through this training, to be the eyes and ears of their area, to look around at their colleagues and see what's happening and what the impact is, and to then use the skills they've learned to offer that support. And the goal is maybe the person in need of support doesn't even know they're getting peer support. It's just that peer is now looking at things in a different light. And if we can all be more supportive colleagues in the healthcare workspace, then gradually culture changes. And so, one of our peer supporters said, I followed up with a colleague involved in a medication error. He appeared to be processing and managing his emotions well. We discussed potential solutions, and he asked for my advice on a similar circumstance. I provided guidance and offered my help if any other circumstances came up that needed troubleshooting. Another peer supporter said, thank you so much for the opportunity to listen to so many amazing stories about caring for others who need our clinicians and experts to achieve healing and comfort. Someone else said the debrief was very helpful and we should do it more often. And another said, I've worked at UCSF for 26 years and it was so therapeutic to have a resource and support for us at such a critical time. And so you can see that people are yearning for this kind of support, given the number of hard things that happen in the healthcare environment. And many times it's not a mistake. It's that patients are really sick and the environment is really stressful and there's a cost to the caring. People are emotionally invested and then clearly impacted when the outcome is not always what we hope it to be. At one peer support training, there was a more senior physician who said, I've seen this clinician response, meaning the second victim response, frequently during my 30 years of clinical training. And after going through the peer support training, he realized, how come I didn't truly see it until today? So really some of this is creating a cohort of people who can come to work with fresh eyes and really be those supportive colleagues that will hopefully help mitigate burnout that the workforce is facing. So thank you all for your time today.
Thank you, Kiran, for shining a light on one of those areas of healthcare that we can call the underbelly. We don't talk about it. We don't look at it. We don't want to look at it, but we have to look at it. So we should go to the website, look at the tools, resources, and each hospital and each healthcare system should consider using this as a template to make something that is appropriate for their environment and then try to go in this direction. So with that covered, we will move on to some situations that are much more challenging and more difficult. we're going to hand over the session to Charu Khanna, who's going to describe her experience and what we can learn from it. Over to you, Charu.
So I'll be sharing my experience with you all. And before I start sharing, I would really like to pay a huge gratitude to Dr. Suri for giving me this opportunity to share the most important message which I've been wanting to for a very long time. In fact, for the past 5 years now. So I'm a mother shattered by repercussions of medical negligence in 2016. My child with MS faced hope through an autologous stem cell transplant, but in that hospital, red flags were ignored. Chest heaviness, breathlessness, and lung haziness post the C-line procedure. Urgent pleas were disregarded. Vital organs monitoring, they were all neglected. Tragically, the fluid bill led to an untimely departure of our child. So let me begin by starting when my child was diagnosed. She was diagnosed in the year 2016 with MS. It's a non-life threatening disease, but unfortunately, over the year, 1.5 years, she experienced 6 relapses, promoting considerations of alternative treatments. After many consultations with and suggestions done with the senior doctors, we decided to pursue an autologous stem cell transplant for our child. The hospital chosen for the procedure was very well equipped with all the modern facilities available. So the treatment began on day one. In the operating room, the C line was inserted for medication administration. Immediately following the procedure, post that, our child started to complain about some discomfort and breathlessness, heaviness in the chest area. These symptoms were repeatedly brought to the attention of all the medical team dealing with her treatment. But sadly, they were ignored. Post the C line procedure, an X ray was also done, which was clearly indicated, which was indicating to haziness in the lung, suggesting infection, as well as an enlarged heart. These critical findings indicated potential complications that should have been addressed prior to the proceeding with the chemotherapy. So, despite raising concerns, urging to the medical team to address to the complications first, the decision was made to proceed with the treatment procedures. The doctors overseeing the case did not adequately address the alarming X-ray findings. So over the time, the condition of our child started to deteriorate with water accumulating around the lungs and the heart muscle. The vital organ functioning, it came to our notice, were also not being properly monitored. The untreated complications and medical negligence resulted in the untimely departure of our child. For this not being, if it was dealt mindfully during the course of those 4 days of our treatment, we would be having our child beside us today. If there were certain safety checks and norms set forth for the safety of patient and treatment proceedings. This is the need of the hour. As we are progressing in the medical field, we need to progress for the patient's safety measures too by setting certain safety checks, as rightly the presentation which was done by Dr. Kiran, it was clearly emphasizing on all the safety norms. And this is what is the need of the hour and needs to be imbibed in the system as soon as possible. So we need to progress for the patient's safety is measured too by setting safety checks at every step of the procedure. Believe me, countless number of lives would be saved. Kindly mull over it and implement on this starting now. It's time to change in the mindset that I am right and everyone has to believe in it. So don't you all agree that we need to make the most important change in the overall approach for treatment and procedures by having a system in place? This mandatory protocol for safety planning is needed and given prior to any complicated procedure to avoid any uncircumstantial incident like how we face the brunt of this negligence. I totally believe that if these safety norms and checkers were set forth then, we would be having our child beside us. And I'm sure the ones are doing the treatment also face the same brunt, don't they? So it's the same mental trauma both the parties go through when the treatment is on. So this should be set forth for the safety and well-being of both patient and the doctors. I'm really sure this change will happen and will start to commence starting now. It's my humble plea. I'm sure by now so many people who have been listening or are going to be listening to this short clipping will try to mull over it and make this change immediately as soon as possible. These safety checkers are very important, and this should happen around the globe starting now. Thank you for listening. Thank you so much. And Dr. Suri, thank you once again for this wonderful opportunity and providing me this platform to share it with so many lives. I hope it makes a lot of difference and tries to bring about change. Thank you for your efforts.
Thank you, Charu, for taking the courage to recite your story once again. We've learned several things. I'd like to go over those points, but first, let me check with Sumita. If Dr. Hutchison is in the session, we'd like his comments. He has a lot of experience in this. So, Hutch, if you're there, can you comment, please?
He's not here.
He's not. Okay. So then we'll go on with making a summary of what we've learned from this story. One is that we should make a checklist. A checklist manifesto is a title given to a book written by a Harvard urology surgeon named Atul Gawande. Many of you might have read his books. Several of them are related to healthcare, improvement in health quality. And one of the things healthcare needs to take is a list which checks off all the items that need to be done before you jump in and do a major procedure. So, before you operate on a knee, the surgeon needs to mark the site. Believe it or not, the wrong site has been operated on, and these steps are needed to avoid that simple mistake. Then you need, checks for anesthesia, checks for labs, and then you go on to putting in checks all along the way to checking the recovery period from anesthesia and then outcome. So that's point one. Two is when you're doing an experimental procedure, it is essential that patient rights be observed and there should be full disclosure. The full disclosure includes getting a consent. And these things are all well described in the literature they should be part of your institution's protocol. And lastly, if there is a poor outcome or bad outcome, then there should be that root cause analysis Kiran was talking about. It should be explored and shared with the patient in an environment that is removed of litigation. I think we should delitigate this area because it's not helping either the patient or the doctors. Okay? It's stress on both sides, and you're just paying somebody else to listen to your complaints. So if we got together and had a coalition of doctors and patients, we had a mandatory analysis and then some outcomes to be taken after a morbidity or mortality, we would all learn and then we would correct, and there would be less chance of this repeating. If there's anything further that I missed, then folks, please add that in at the end. But because of the time constraints, we're going to move on to Ms. Japneet Bawa's experience, and she's going to share what she went through and what we can learn from it. So over to you, Japneet.
And how the doctors go through burnout, and how the doctors also need compassion from us and understanding from the patient to the doctor. So basically, while you guys were talking, I was thinking on that aspect. But my story does not include that somehow, because here we have not blamed the doctors as yet. We have not even confronted the doctors with what happened. It is a story of misdiagnosis of a child, my daughter, and she was suffering since she was a kid. It took us a couple of years to notice the suffering because we kept thinking she's a spoiled child. She's just throwing tantrums. After many years of misdiagnosis, we found out that that was not epilepsy. It was non-epileptic psychogenic seizures, which are very similar to complex partial seizures. Now, this is the doc language that I do not understand, but this is what I've heard year after year. So she was diagnosed with epilepsy. We had gone to we went to a couple of psychiatrists. We wanted to choose the best for her. We thought it was a mental health issue. So we chose the best psychiatrist, and he suggested getting an EEG because he was very, very sure, quite certain that it is complex partial seizures. So we went to a very good doctor, a very, very good doctor, retired from from a very, very renowned institute of India. And he did her EEG, and he agreed that she had complex partial seizures, and he put her on Tegretol. He put her on anti-epileptic meds, one or two, I guess. And then there were regular checkups, and each time they said it's getting worse. Started from left temporal lobe, went on to frontal lobe, and then eventually came to generalized seizures. Then we went to other good neurologists, again from very, very reputed Indian institutes, and they all said that she's very serious. Her epilepsy is getting worse. They kept increasing the meds, and there was no relief. Initially, with the medication, the episodes had reduced. She was having rage attacks when we went with the problem. So they would last for a couple of hours and then subside on their own. But there was a fixed time. And when we went, we thought it was a psychiatrist domain. We were eventually sent to the neurologist. So one to the second, third, fourth, fifth. So we managed around 6 neurologists in India. One of the best. We even sent the reports abroad to Indian-based doctors. And eventually they kept telling us that it's getting worse. And then the first doctor that I'd gone to, who had diagnosed her with epilepsy, he said that, how much are you going to make the child suffer? You need to go to Johns Hopkins for a surgery, if you can afford it. Why would you let the child suffer for 4 years? She's continuously coming to us and deteriorating. And so we started contemplating on that, and we started doing our research. And then my uncle, a very well-known doctor in India, he suggested that we move her to an institute for 1 month where they can monitor her and evaluate her psychologically as well as with epilepsy in mind. So they did it for 1 month, and they said we see the same discharges in every EEG, but we do not see epilepsy. So what they meant was that this is psychosomatic, these are PNEs, and this is not epileptic seizures. Now that was very good news for me, but they would not give it to me in written. And they said it is still under evaluation. And then they diagnosed her with multiple mental health issues like depression, anxiety, and PTSD. And OCD was a question mark. So this went on, and after that, we found you. And that was the only God sent thing. And you saved our lives. You saved Naira's, my daughter's life. And we all, after that, rest is history. So now she is in the process, what we lost. I would like to talk about that. She lost her education. It stopped in grade 4th, and she rejoined in grade 8th when she should have been in the grade 10th. And she gained 30 kgs of weight. She was traumatized by that. She got depression due to that. She got anorexia later, and multiple mental health issues came up with that. And today she's anorexic. She's got bulimia, that self-inducing vomits and stuff like that. She's into self-harm. She's got depression. She's got anxiety. Each day we have a new challenge, and we are still. It's like every day is a new day. Some days are good. Now, since the last week, she has been taking out blood and vomits. So, and the vomits are self-induced again. So, I don't even know if the psychogenic non-epileptic seizures are over or not, and whether it's just the mental health issues that are carrying on. But it was all due to the negligence of almost every doctor I went to, and I'm pretty sure nobody did it intentionally. So how did it happen? That's something I really want to talk about. They could not read the EEGs. They could not read the EEGs well. They could not read it the way they were supposed to. If they could read the EEG, they would have known from day one that she does not have epilepsy. And she wouldn't have suffered, the family wouldn't have suffered, and we still are suffering. But I thank God that the child is still with me. And a lot has been reversed thanks to you. But yes, the journey has been a roller coaster and still is a roller coaster. But what this patient safety and doctor burnout, we were discussing that. I can't even talk about that because I have not spoken to any doctors about it. I've not gone to any doctors with this concern that what have you, I've not confronted them. So that's the story. And I don't think it'll help doing that. It will just not help. The only blessing is that she's out of it now. We have other issues. They keep changing. They keep coming back. And we are dealing with them. But at least the misdiagnosis is over.
Okay, I have Dr. Hutchison online.
All right.
Thank you, Japneet, for taking the time and the courage to tell us about your experience.
Thank you.
And you've got a very strong will and courage to come forth and help people understand what went wrong and how we can fix it. This problem of EEG misdiagnosis, let me silence this. Dr. Hutchison's on the call, and he's heard your story. Why don't we ask him his experience?
Yes, please. Yeah, I would want to know that.
Hutch, it's over to you.
So I just heard part of the story. it's a tragic story, and I read some of the events beforehand. There's several things to say about this. First of all, it's hard to jump to conclusions about what happened. Some patients with PNES, psychogenic non-epileptic seizures, can have very complex problems, and you don't know how much of that is mental and how much is epileptic. So if you do an EEG, you said there were some discharges, so maybe she has an abnormal EEG anyway. And apparently what they did when they monitored her was show that the discharges are independent of the behavior. Is that correct?
What I was told each time was that they are discharges, and they are epileptic. They are epileptic seizures that she's going through. But when I went to that institute and got her admitted, they said we see the same discharges, but they are not epileptic by nature. And I was also told that complex partial seizures are similar looking as PNEs. Therefore, doctors find it very difficult to differentiate between them. I don't know how true that is.
So I think all of that is, I'm going to have to try to imagine what actually happened, because I don't, so they never did any surgery, is that correct?
No, not at all.
Okay, good. So EEGs can be abnormal, and
Yes.
sometimes the EEG is abnormal without knowing whether that's the actual behavior or not. So that's the purpose of the monitoring, so that if there are discharges you can see, then the next question is, do they correspond in some way with the behavior? And apparently they did not. So how do you have epileptiform changes on the EEG without having seizures? That's quite possible. Not common, but would suggest that there's some dysfunction of her brain anyway, but it doesn't result in a seizure. A seizure would be like an electrical storm in the brain. So what you would expect to see when you're monitoring is that there's a discharges or evidence of an electrical storm during the event. Now, you mentioned there were rages that went on. I've certainly seen kids who have a brief seizure, and then that's followed by some behavioral change. But it often becomes very difficult to know exactly what happened. So it sounds like that they did the right thing at the epilepsy center by doing a careful monitoring and deciding that that the events that she were having were not seizures, that is a discrete electrical storm in the brain.
Yes.
But she did have an abnormal EEG, apparently.
She
So
always
maybe
had an abnormal EEG, always.
So what does that mean? I don't know what it means. Some people have an abnormal EEG who appear to be normal, and then there are other people who may have some brain dysfunction that doesn't result in seizures, and the EEG changes are just a marker of that. So if she has behavioral problems or mental health problems,
She does.
it's caused by some brain dysfunction that is not epilepsy.
Yes, that's what we found out later, that it is all psychological. It's all related to mental health issues. She had rage attacks. She had abnormal behavior, and this would last for a couple of hours, and that was it. So
why does she have behavioral changes? And why does she have an abnormal EEG then? Does anybody know that?
nobody knows nobody has those answers.
Can I give you the summary of what I saw and what my team saw?
Yes.
All the EEGs that were available to us that we did and which we reviewed, not all were available. All of the ones I saw were normal. And
Okay.
what we saw was usually sleep activity, which is commonly overread and is called as epileptiform.
I'll bring something back for you.
All right. My wife is talking to me in my ears, so it's hard for me.
I'll bring something for you.
So Anyway, so all of the EEGs that you saw were normal. Is that correct?
Yes.
Okay, so we don't know whether she has brain dysfunction that we can see or not.
And
so what is mental health? It's something that goes on in the brain for sure. You can't have mental health problems without having a brain, but it may not be epilepsy. And so if you go to a center and they look at discharges and they see they do not correlate, then what that says is you really shouldn't treat this as epilepsy because the epilepsy medicines may not help, although they might. And you certainly don't want to operate because there's nothing in there to remove. So, but you still have the underlying condition. I don't know what mental health is. I know that it is physical in the sense that something's going on in the brain, but seizure medicines usually don't help. And unfortunately, some of the psychiatric therapies also don't help. So somebody may be seriously disabled long term. So it sounds like that the best thing was that you got monitoring from an epilepsy center. They said this is not epilepsy. We don't know what it is, but it's not epilepsy. So
I want to give a feedback on what happened just a month ago. She was under what Dr. Suri thought was a PNE, a seizure, because she got unconscious for 4 minutes. And then after waking up, she had what a psychiatrist said, psychosomatic movement disorder. For the next 15 days, she could not handle the weight of her legs, her shoulders. They were trembling, they were shaking, and we had to assist her in walking. Until today, and this happened for 10 days, until today, when she's under acute stress, her legs start trembling and it slowly goes away on its own. I have never heard or seen such a thing before.
So I understand that. I have a man that I've taken care of who sometimes we can find a pre-existing cause. This man had an extremely traumatic past. I don't want to give all the details, but his home life from the very beginning was extremely disrupted with physical and mental violence. He belonged to gangs for a while, and he was in prison for a while and became an alcoholic, but has now come out of that and has checked himself into rehab. His problems are not over, but he has an ongoing movement disorder. He's walking down the street and all of a sudden will be consumed by spasms that sometimes cause him to fall. He's even been unconscious. We've had the ability to actually record some of these events on the EEG while he's having them, and we see that the EEG is normal. So these are what appear to be seizures. They are not epileptic seizures. So we call them psychogenic non-epileptic seizures. We don't know what caused them. That's the bottom line.
Yes.
He's pretty badly disabled by all of this. What we've been doing in the last few months is to do some programs that involve cognitive behavioral therapy, and he's doing a bit better, but I don't want to go into all the details of that case. But what that shows is that somebody who's 40 years old can have very bad problems all their life that look very much like seizures, but the EEG shows that they are not seizures. So what can we do? He doesn't respond to antidepressive medicines. He doesn't respond to antipsychotic medicines. But people with non-epileptic seizures do not usually respond to those drugs or to the anti-seizure medicine. So it's a mess.
We'll summarize the last case with the key points we learned here. For patient safety, we want to make sure that young children are not exposed to, in this case, up to 12 medications at a time, and that they are not placed on them without a definitive diagnosis, that we work towards a more accurate diagnosis, which we can talk about later. We are in the process of trying to set up good EEG for this. Go ahead, Japneet.
The only concern why I'm sitting here is to request the medical fraternity to be able to read, to teach the people of India, or at least whosoever, as many countries as you can, to read the EEG correctly, because people are suffering, misdiagnoses are happening, something can really go wrong. We were lucky, but everyone
So
else must have been
unfortunately,
lucky.
EEG is, I mean, even if you look at the Bible, people read the Bible, they're supposed to have all the answers and they come up with different interpretations. So EEGs are not quite as accurate as the Bible. So, you can be a good EEG reader and still not get the answer. So you have to have interaction between mom and the child and so forth. And the bottom line, there are bad diseases out there that aren't epilepsy. And fortunately, she wasn't operated on, so that's good.
Yes,
We
yes.
need to
Thank
stop,
God.
Madhav, so I'll go from there. But I want to emphasize that communication with the families, respectful communication, and judgment are extremely important. So I think, Japneet, if we need to talk later, I can do that in another setting too.
Thank you so much.
We'll continue this tomorrow when we all four will be in another session
Yes,
on the
yes,
hospital scorecard. But at this
yes.
time, I think we'll have to wrap it up. We are working, Japneet, on your request, and we are going to set up the EEG training program
PG
even
Training Center,
greater.
yeah.
And we're going to focus on pediatric EEG, which are harder to read than the
Very true.
adults.
Very
Okay,
true.
at that point, we will end now
Thank you
because
so much, Dr. Suri. Thank you so much.
thank you for coming on. Thanks,
Thank you.
thank you, Charu, for
Thank
being
you.
there.
Thank